Good morning, everyone. Welcome. We're very excited as the first session of the medically led sessions. It's exciting to get launched with this conference. Just so everybody knows, you're at Basics of Pulmonary Hypertension, everything you wanted to know about PAH, but you have to ask. I'm Murali Chakinala. I'm a pulmonologist or lung specialist at Washington University in St. Louis, and I have a great panel here helping me today, and we're going to get started in just a minute. I just want to let everybody introduce themselves. You want to go first, Paul?
My name is Paul Fairman. I'm a pulmonary physician at Virginia Commonwealth University in Richmond, Virginia.
I'm Aaron Waxman. I'm in the Pulmonary Critical Care Division at the Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts.
I'm Joel Wirth. I'm another pulmonologist, and I'm at Maine Medical Center, which is part of Tufts School of Medicine in Portland, Maine.
And I'm Maribeth Duncan. I'm a nurse practitioner at Washington University with Dr. Chakinala.
I guess I didn't do the politically correct thing by inviting a cardiologist to the panel, so you have to forgive me. We don't need him. You heard the title of this session, and I think it begs to sort of a certain type of audience member. If I may ask, how many people, is this the first time you've been to PHA, the international conference? Great, so a lot of people. That's wonderful. Come on in, folks. There's lots of seats up here in the front, too, so help yourself. How many of you are, let's say, been diagnosed with pulmonary hypertension in the last year? Okay. Good. So, I think this session is, like all these sessions, we want to keep this very interactive. We're going to limit our comments to just for the first 15 minutes or so, just to set the stage. But we really want it to be a opportunity for you to ask questions and get our responses, make it as interactive and as fun as possible. So there's no slides. There's no fancy diagrams here. It's just off-the-cuff comments and Q&A. So I've sort of asked my fellow panelists up here to have several of them to say a few words about one aspect of pulmonary hypertension to, again, sort of get the juices flowing here. So, Paul, can you maybe just in a few minutes talk about sort of normal anatomy and physiology of the heart and lung, how it's supposed to work?
So you heard my assignment. It's basic circulation of the blood, heart-lung anatomy, and physiology in 5 minutes or less. Thank you so much.
You're losing time.
That's okay. I can make it. Okay, we're going to start with the heart. The heart's a pump. Its job is to circulate the blood. It has to pump it around. And you have to think about the heart really as being two pumps. It's not just one, it's two. You got one on the right side and one on the left side. Very scientific system here. You have two pumps. You call one right and one left based on which one's on the right and which one's on the left. It's easy. The right heart is meant to pump the blood into one place, the lungs. The left side of the heart pumps the blood everywhere else in the body. So when we're talking about pulmonary hypertension, we're talking about high blood pressure in the lungs, and the right side of the heart is the side that has to work hard in order to generate that pressure, in order to keep things circulating. With each contraction of the heart, left side, right side, blood is moving. From the left side, where is it going? It's going to the brain, it's going to the muscles, it's going to the kidneys, it's going to the intestines, it's going everywhere else except the lungs. And the lungs, the right side of the heart, is pumping it into there. Those two pumps are actually one organ. They sit in the middle of the chest, right heart, left heart, but they're right there in the middle of the chest. And the circulations then are interesting when you try and tease them when you see a diagram of the of the circulation, you can see that these vessels are turning and going all various parts in the body, but in the chest, it's really all about circulation, the right side going to the lungs. We can easily make a measurement of blood pressure coming out of the left side of the heart. Put that cuff around the arm, blow up the cuff so it's nice and tight. That stops the blood flow. We can listen with a stethoscope. When we hear the sound coming back, that tells us that's the top number of the blood pressure. And when it disappears, we can say that's the bottom number, so it's easy to do. How do we measure the blood pressure in the lungs? We can't get a cuff around it. So we have to actually make some assumptions about how it works, or we can put it in through a catheter and we can actually measure it directly. Or we can do it indirectly with an echocardiogram, which we can see the functioning of the heart and we can measure some things that help us estimate the pressure. So we can actually measure it directly with a catheter. We can estimate it with an echocardiogram. We can get some idea about how well the heart is pumping against that pressure with the echocardiogram. A number of other tests that can be used to evaluate without doing that catheterization. But when it's necessary, that is the test that's most valuable for evaluating pulmonary hypertension. Now the next section, I think, is what goes wrong in pulmonary hypertension, and I think that's up to Aaron, right?
Yep. And I only have 5 minutes, too. So it gets a little more complicated when things start to go wrong. And I think what Paul pointed out is a key feature of the whole system is that the lung is unique because it's the only organ in the body that has to receive the entire output of the heart with every beat, whereas the left side is pumping to the entire body, spreading that output throughout all the organs. So that means that whatever happens in the lung is going to have a direct impact on the function of the heart fairly quickly. For the right heart to work normally, the lung has to be able to accommodate big changes in blood flow. So if you think about when you exercise, if you're just sitting here right now with every minute of your heart beating, you're pumping about 4 liters worth of blood. If you now start walking or exercise, you have to increase the output of the heart, the pump, and increase that flow anywhere from 2, 3, 4 times what it is at rest. The lung has to accommodate all of that. So the lung blood vessels have to be able to distend and open up and just let more flow through. So the real problem in pulmonary hypertension is not the pressure, even though we've named it on the pressure. It's the resistance. The resistance has to do with the pipes and how stiff they become. So what we've learned over the past 20, 30 years is that it's not a problem that these vessels are constricting or squeezing. It's that they're abnormally getting thicker and stiffer because cells are multiplying, cells are migrating in some ways similar to what happens in a cancer, but it's not a cancer, it's just abnormal growth in these blood vessels. The end result of that abnormal growth is these vessels are getting thicker, they can't distend, they can't accommodate these increases in blood flow, and over time, the heart, the right heart, starts to get bigger, starts to dilate, and really starts to become inefficient in how well it pumps the blood. As that inefficiency progresses, you feel short of breath. Although the true reason we feel short of breath is probably much more complicated than that. But that's the root cause of it. So our whole concern with pulmonary hypertension and worsening resistance into blood flow is how long can we maintain good, normal heart function. And that's our goal of therapy. And I think Joel is now going to talk a little bit about diagnosis and the necessary steps to figuring out why you have pulmonary hypertension.
Okay, good. So pulmonary hypertension as an entity was kind of first described pathologically about 100 years ago. How much time do I have?
5 minutes.
5 minutes, okay. So
Not fair. I mean, everybody gets the same.
It's good. The catheterization techniques were really developed in the 1950s, and that's when physicians really started to describe abnormal pulmonary blood pressures and started to understand what normal was and what abnormal was. In about 1975, the World Health Organization started a series of conferences to try to define the disease and really understand its natural history. There weren't really any treatments for it at the time, but they felt they needed to categorize it in order to better understand it. And since that time, about every 5 years, there's been consensus conferences to really try to classify the disease. And the classification scheme has really come out of how we diagnose it. And so there's 5 categories currently of pulmonary hypertension. I think most of the people in this room probably have group 1 pulmonary hypertension, which is called pulmonary arterial hypertension. And this is really pulmonary hypertension that just involves the blood vessels in the lungs by and large. It doesn't involve the heart. It doesn't involve pathology of the lungs. It doesn't involve other problems. Now, it can be caused by other systemic diseases, such as scleroderma or liver problems or other kind of conditions. But the issue with the cardiopulmonary circulation is really it's a small blood vessel lung problem, and specifically it's the small blood vessels in the arteries just before the breathing sacs in the lung. And so that's really where the problem lies fundamentally for patients. Now, for patients with PAH, or group 1 pulmonary hypertension, that's where a lot of the drug development has really come about in the last 10 years. We now have about 9 different treatments, both pills and inhaled and IV therapies. Okay? The other groups, so group 2 is pulmonary hypertension due to heart disease. That's actually probably the largest group of patients. Okay? So group 3 would be pulmonary hypertension that's associated with advanced lung disease, so people with really bad emphysema, people with bad pulmonary fibrosis, people with sleep apnea. Group 4 is patients who have chronic blood clots, so pulmonary emboli that plug up the vasculature and block the blood flow. And then group 5 are diseases that we really don't understand how or why they're causing pulmonary hypertension, but we can't really put them into the other 4 groups. So it's kind of a wastebasket category, but any good classification system needs an extra category. So the diagnosis is really important. The whole goal of diagnosis is trying to determine which group the patient is in, because all treatment flows from which group the patient falls into. So as we do the diagnosis, we will put people through history and physical examination and EKGs and echocardiograms and lung function tests. And these are to help separate out, are you a patient who's a group 1 patient, a group 2 patient, a group 3 patient, or a group 4 patient. Because there are different treatments for each group. So because treatment flows from diagnosis, it's really important to have a thorough diagnosis. Okay? And so that's why when you've met your pulmonary hypertension treating physician, they've probably signed you up for a lot of testing because it's really critically important to know what we're dealing with. It's nice that the groups are all separated. Real life isn't quite that simple, so there are overlaps between these different groups. And so you can have a little bit of this and a little bit of that, and that's where the rubber meets the road in clinical medicine, where it becomes, the challenge of how you manage certain patients. And it's the diseases all have very different manifestations, and they have even within the same family sometimes, and so that's the real challenge of it for everybody involved is sorting those things out.
Great. All right, thank you very much, and we did it all in 15 minutes. So hats off to the panelists. So you heard a little bit about how it's supposed to work, how it doesn't work properly in patients with pulmonary hypertension, and how we as doctors sort of get to that, go through the evaluation to figure out what's going wrong here. I think analogies were made to cancer. I think just being told you have pulmonary hypertension isn't enough. It's like just being told you have cancer. I mean, you have to know what kind of cancer to know how to be treated, right? Lung cancer is not treated the same way as a leukemia. So that's why we go through a big evaluation, as Joel mentioned, and culminating in that heart catheterization, which I kind of view as the biopsy of a cancer to know exactly what it looks like. So we're going to open it up now for questions in the remaining 45 minutes. I encourage folks to raise their hand. We'll have microphones coming around. As a general disclaimer, we are happy to field questions and do our best, but please keep in mind that we cannot take the place of your doctor. We're not here to prescribe or tell you what you have to do. Look at it as general advice to educate yourselves and learn more, and perhaps go back and speak to your doctor about something. Okay? This question up front here. Folks up that are back there are some seats up here still. Feel free to come on up.
Yes, I have a question. I think my wife is in group 5. How common is iron deficiency anemia with PH? And also, what are the complications that iron deficiency anemia imposes on the process?
I see. That's a great question because I think it's probably under-recognized. So you can see iron deficiency anemias for a number of reasons. We certainly see it in combination with some forms of pulmonary arterial hypertension and pulmonary hypertension in general. In fact, there is some research now going on that there may be defects in some of the proteins that carry oxygen and actually have problems with iron binding as one of the mechanisms for causing the disease. Also, some of our drugs cause anemia. Some of the endothelin antagonists especially can cause anemia. And then one also has to make sure that there's no ongoing blood loss from something in the bowel that could be causing iron deficiency anemia. So it's probably something we see not uncommonly, but we don't always know why. But certainly there are some obvious causes that we have to investigate.
And it does, just to expand on that, it can have a significant impact in how a PH patient feels. Okay, so I try to explain this to patients in thinking about that our body and all this. Imagine that you're running a trucking company and you've got to deliver a product. In this case, it's oxygen. Okay, and if the trucks move really slowly, like they already do in pulmonary hypertension, because the pump is weak, it's going to take longer to get that amount of oxygen to where it needs to go. Well, if you've got fewer trucks to carry the oxygen as the anemia patient, it's going to take even longer to get that oxygen delivered. So it is one more thing that can make PH patients feel bad, and it's easily fixable. So it is something that I know at our center, we pay a lot of attention to and are aggressive about treating it. It's a good question, though. You want to hang on one just second? I'll get a microphone so everybody can hear you. Thank you.
In controlling celiac diet, asthma, reflux-induced asthma, which requires antacids, which are suspect in causing some of the problems with the lungs from whatever. What recommendations what can you tell me about that? And also the drug Levaquin, which I think triggered it all.
So are you saying that with those other problems, how do you treat the iron deficiency? I'm not up on my celiac diets at this point to know where your limitations are. I mean, I think the important thing is to make sure you're getting enough iron-rich foods that won't interfere with your diet. And even if you're not, there are clearly ways to supplement iron, both orally and even now fairly safe intravenous iron preparation, so that if you just really can't do it with your diet, this goes for any patient, you can get intravenously iron periodically to increase your stores.
I would also just caution that sometimes iron-loaded diets, you don't want to have too much iron, but the other thing is for those patients on Coumadin, you have to be careful about your diet, and it's probably something most clinics, certainly at our PH center, and I think most of them, there is a dietitian usually available that you could sit down with, go over what you eat and what you need, and get a detailed prescription, really, of what would be best to supplement your diet with.
I was diagnosed in March with
what I was told was PAH with left heart disease. And since I've been here, I haven't heard a word about that. Can you explain to me a little more clearly what they're talking about when they talk about left heart disease? I was lucky enough to sit at a table this morning with the doctor who treats a lot of people with this, and basically what he told me was completely the opposite of what I was told by my diagnosing cardiologist.
Joe, do you want to take this one?
Yeah. So PAH is group 1, which is really just a blood vessel problem in the lungs, and the heart is generally, the left heart is generally normal in those conditions. So the right heart can be affected because it has to pump against that high pressure, and so we will see abnormalities in the right side of the heart, but it's kind of an innocent bystander in that, we think, presently. So it's not the cause of the pulmonary blood vessel problem, it's a recipient of the high pressure it's pushing against. Some patients, so group 2 patients have, and I should have been more specific about this, they have left heart disease. So if you think about the blood flow as a stream, there's a dam in the bloodstream, and the dam might be a narrowed valve on the left side of the heart. So, where the blood is trying to come out of the lungs and it runs up against a blockage in the left heart. It can happen because the mitral valve or the aortic valve has either a narrowing or is leaky. It can be because the left ventricle, which is the sump pump for the lungs, it drains the lungs, either pumps not well enough or it doesn't relax well enough. So it can't accommodate blood flow, or it can't pump blood flow coming out of the lungs. And so, as I mentioned, when we think about pulmonary hypertension, we try to segregate people into these different buckets, into the group 1, group 2. But the real world is that we do see patients who can sometimes have 2 conditions, so you can have pulmonary arterial hypertension, but have kind of a mixed picture where you might also have a little bit of lung disease or a little bit of heart disease. And that's the challenge of trying to treat anybody is to separate that out. It's nice when people only have one problem and it's clearly identifiable and there's no other issues. And we do see that in some patients with PAH. When we see a 30-year-old, for example, with severe pulmonary hypertension, it's usually fairly obvious what the cause is. But when you see an older patient, there's multiple problems. And we're fortunate now that, fortunate and unfortunate, I guess, that we have patients now that are living long enough that we see them with PAH, and then they go on to develop other problems, sometimes other forms of pulmonary hypertension even. So that's where it gets a little bit complicated. And that's where the right heart cath is vitally important. So before anybody gets started on PAH-specific therapy, you need to have a right heart catheterization to exclude heart disease in particular.
Well, I had a right heart cath, and my right ventricle is fine. My pressures were mild to moderate. I had a high wedge pressure, and that was the basis for the diagnosis of left heart.
Yes, so that high pressure that we're seeing from the left heart indicates that the pump is not working well on the left side. It's not draining the lungs adequately, so there's a back pressure.
And I was also told there's nothing they can do about it.
Well, there are some medications that can be done about it, and that's where you need to work with your cardiologist or your pulmonologist. And
cardiologist is where I got all the wrong information.
Well, and you bring up a great point, and there is a lot of confusion out there, and the medical community is, quite honestly, mostly to blame for that, because I think we toss the terminology around very loosely. If you come to this meeting and talk to a group of PAH experts, use the term PAH, that means something very specific to all of us. But you go out there in the community and you speak to the average practitioner, who is probably a very good physician, don't get me wrong, but they may just throw out the term PAH and not even implying what we're saying. So it gets confusing in the literature, and our colleagues, even at our institutions, we see reports from the radiologists and other people. They're always throwing out the term PAH when they're not exactly specifying group 1 disease. So it gets very confusing. And, if if you leave from here with knowledge that makes you question or rethink something, you obviously can go back and speak to your doctors about this. Well, what do you think about this? And if, you're not getting the reception you need, you're always welcome to get a second opinion. But I think it's critical, though, to go through the steps that, we're talking about, which it sounds like your doctors did. And now it's a matter of sort of interpreting that information, which sometimes, there can be mistakes made there, too.
We have a question back here.
Okay.
I've been having PAH going on 6 years. I was diagnosed 6 years ago. Now, I just found out last year there is 4 stages in PAH, and I'm in my 3rd stage. But 4 is the critical. Am I right?
Yes, I think what I presume you're talking about, ma'am, is what we doctors call functional class.
Yes.
Yeah.
Yes.
So you're right, there are 4 stages or 4 classes, and this is something that we have borrowed from our colleagues in cardiology who've been treating heart failure on the left side of the heart for decades, and they have a classification system called the New York Heart Association classification, and then we modified it a little bit to the modified World Health Organization classification. And this is just a subjective assessment that your healthcare team would be making by talking to you in clinic and judging how symptomatic you are. And the more symptomatic, and in essence, the less you can do in your daily routine without experiencing symptoms, the higher your functional class. And why that's important is, it's number one, it's a way for us to communicate with each other to gauge how sick someone is. It's a way for us to sort of track your condition. So if you were functional class 1 or 2 a year ago and now you're 3, that's worrisome that your condition is progressing. And a lot of times we base our therapies on which drug to give based on which functional class you're in. The higher the functional class, the more concerned we are, and the more likely we may be to offer advanced therapies beyond just a pill.
And another thing I wanted to ask, what's the difference in the PHA and PH?
In PAH and
Yes.
PH?
Yes.
Okay. One of you want to?
Sure. So, to go back to this, so PAH is group 1 disease. That's where people just have the small blood vessel problem in the lungs. PH encompasses all 5 categories. Okay? So that's why if you're told you have pulmonary hypertension, it's not very specific for us about what form this is or how to treat it. So you need to know which group you're in to know how to treat it. And just to follow up to what was mentioned about the functional classes, so not to think about the functional classes necessarily as patients start out with 1 and then become 2 and then become 3 and then become 4. We use it as a way to describe how sick people are, but people can move in either direction depending on treatments, okay, and how they respond to those treatments.
And one more question I wanted to ask. They still don't know how we got to PH. I was diagnosed, when I first was diagnosed, they said I had a cold. And then 4 days later, they came up with the PH. So
it's hard for us to say much about that since we don't know more of your, history. So,
Could you address pulmonary venous hypertension? Does it fit into this at all, or how does it fit?
That's group 2. That's group 2. The problem there is the heart function. The left side of the heart function is not as good as it should be. And therefore, since the left side of the heart is not pumping blood as efficiently, it generates a back pressure into the lungs and elevates the blood pressure in the lungs. So it's the most common form of pulmonary hypertension in adults. Group 2. It's not PAH.
The reason it's called venous is because when you think about the difference between arteries and veins, arteries take blood away from the heart, veins take it to the heart. And what you're getting is a back pressure into the pulmonary veins, which are the veins that come out of the lung to the left side of the heart. So it's the same thing that Paul and Joel have been talking about with this backwards flow. It's just being a little more specific as to where the problem is. But over time, if it's not treated aggressively, you can see the same kind of remodeling in the blood vessels, the thickening and stiffening, all the way through the lung so that it can have an overlap with PAH as well.
So the endothelium is in the vessels completely, not just the arteries.
The what?
The endothelium problems?
You mean the molecule endothelin? Yeah, it's released in all blood vessels. It has effects in the lung and the kidney as well as other vascular beds.
Question back there, and then we'll come up here to the front. I know you've been anxiously waiting.
Yeah, I was newly diagnosed, determined by an echo, and I went to see after that I went to see a specialist, expecting a catheterization, which he did not do, but he did a second echo. Why wouldn't the catheterization have been done? I know you don't know my history either, but can you? I would think that would have been done.
I'm going to take a shot at that. Echoes are of variable quality. I would like to say that they're all good. I would like to say the interpretations of the echo are all excellent, and that once it's on a piece of paper that your results were A, B, and C, that we could all believe that. But there are differences in the quality of the performance of the test and in the interpretation of the test. So if your second doctor was not happy with the first report or something about the way the test was done and still needed the information, then a second echo would be appropriate.
But I would add, though, you cannot make a diagnosis based on an echo.
Right.
You have to have a right heart cath to get a diagnosis. So if you had a repeat echo, it may just have been less concerning to that second doctor. And there's a real art to looking at the echo and seeing what's on that echo to make the decision whether you need a right heart cath or not.
And keep in mind also that when we look at the echo reports and look at the echoes themselves, yes, we get an assessment of the pressure, and we do pay attention to that, but as Paul and Aaron just mentioned, there are inaccuracies about that. We look at the whole picture, though, because, as we've said, the majority of the time that we have pulmonary hypertension in our country, it's usually due to underlying left heart disease or maybe lung disease. And so maybe that second doctor noticed something that was abnormal on the left side of your heart that could explain any mild pulmonary hypertension and didn't feel like a cath was necessary. And the other thing we also look at, not just the pressure, we look at indirect signs of that high pressure, meaning if you've had high pressure in the lungs and pulmonary hypertension, the echo suggests that, you generally see other things wrong with the right side of the heart, as was mentioned earlier. The right side doesn't like dealing with these high pressures. And the counter to that is if the right side of the heart looks totally normal, while it couldn't exclude that you have pulmonary hypertension, it's at least reassuring to us that maybe there's not much wrong here in terms of the pulmonary hypertension. So it's not just looking at the pressure. We look at the whole picture, and these are some of the reasons maybe why your second doctor did not pursue the heart catheterization. So maybe we get a question up here.
Thank you all very much. I have two questions. The first one is for my daughter. She has an ASD, and she's supposedly stable enough, or her numbers are looking good, that the doctors are considering to close the ASD. And the question that I have is, does ASD now cause the venal pulmonary hypertension, meaning the backflow that you guys are describing? And the second question, is there anything in the works for an artificial lungs?
So the issue of congenital heart disease is it's very case specific as to whether these passageways through the heart can be closed or not. There is a growing effort to close them in the right circumstances. So if you get a very good response to therapy and the pressures come down and the resistance goes back to normal, then we can close some of those. We can't close all of them. So if they feel that they can close it safely, and that means that the heart function is probably normalized and the pressures and resistance have markedly improved, if not normalized. Not everybody, though, can be closed, and we think of these holes sometimes as blow-off valves so that they're actually protecting the right heart in certain cases from failing. But we do close some of them, but it's a case-by-case basis. As far as artificial lungs, we are working now on regenerative approaches to lung disease. It's probably something that is much more focused on lung diseases themselves, like emphysema and interstitial lung disease. As far as growing new blood vessels, there is a study going on right now in Canada, but it's very, 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 very early. And I think we'll probably see efforts to regenerate pieces of lung well before we see opportunities to generate blood vessels.
So just a word on diagnosis here. So an ASD is a hole between the two smaller chambers in the heart. For people who aren't aware of what that is, it's called an atrial septal defect. There are also holes between the two main pumping chambers in the heart called ventricular septal defects, or VSDs. These are forms of congenital heart disease. The attempt is usually to fix these very, very early on, before in the infancy, basically, for most patients when they're discovered. If they're undiscovered and they go on, they can create pulmonary hypertension for a variety of reasons. And pulmonary hypertension in those patients is considered group 1. So it's not from a high back pressure, it's from damage of some form to the pulmonary blood vessels that occurs over time. So left unrepaired for long periods of time, patients can develop pulmonary arterial hypertension, group 1 pulmonary hypertension, and it's more common with VSDs than ASDs, but it happens with both. So just to further complicate things.
Yes, I was diagnosed 3 years ago with PAH, and I had scleroderma for 10 years before that and was diagnosed with pulmonary fibrosis and was treated with Cytoxan that stabilized it. My question is, my recent shortness of breath, they're saying they don't know if it's coming from the PH or the pulmonary fibrosis, and I was thinking the fibrosis is what contributed to the PH. Can you explain maybe where the thinking is on that?
Pulmonary fibrosis, a stiffening of the lung tissue, is also a destruction of some of the small blood vessels that are important to circulation. So if there is extensive scarring of the lung tissue with loss of enough blood vessels, the pulmonary artery pressure will go up. That is true. That's not the most common thing that happens, though. For patients with pulmonary fibrosis, usually the shortness of breath comes long before there's any element of pulmonary hypertension. But it's sometimes difficult to know without doing the appropriate testing whether pulmonary hypertension is part of the problem or not.
Okay. I have one other question. When I have my blood test with my pulmonologist, the pro-BNP, like one time it'll be 194, and then the next time I go it's 700 and something. And she says not to worry that it goes up and down, but those numbers worry me. Is there any cause for that, or why would it go up and down like it does?
So those numbers, it depends on what the normal cutoff is for your hospital. I can tell you for our hospital, those numbers are both in the normal range.
Okay.
And there is variability. The BNP, or the pro-BNP, which is probably a better test, BNP goes up when the ventricle or the atria gets stretched. Mm-hmm. So what we're looking for in those cases are if they go up high. And usually that would correlate with you feeling more short of breath. And then we can treat you with diuretics or other medication to bring that number down. And so that's what it's used for. But there is a lot of variability, especially within the normal range. In our hospital, it can go from about 100 up to 1,000 and still be normal.
Okay, thank you.
Yeah, we throw a term around a lot in our circles about surrogate markers, biomarkers, excuse me. And we don't want to have to do a heart cath every time you come to clinic. I mean, it's just not possible. So we've developed and have evolved into using simple, non-invasive, hopefully cheap tools. The functional class was brought up earlier. Everybody knows what a 6-minute walk is. You know, you probably get one of those to most of your visits to the doctor. And the BNP is another one that some people use. But, you know, those coupled with your symptoms and what you're telling us are the sort of the things that we put together to understand how you're doing from one visit to the next. All right, where's the microphone? Oh, yes, ma'am, go ahead.
Have you had a lot of patients who've had severe memory loss because of the lack of oxygen basically going to the brain for a long period of time with pulmonary hypertension?
No.
Well, just about everybody I talk to who has pulmonary hypertension does complain about their memory, but the doctors seem to say it's got nothing to do with pulmonary hypertension.
Well, I wouldn't be absolutely certain about that. I can't be firm in saying, no, pulmonary hypertension doesn't cause memory loss, but there are a number of things about pulmonary hypertension that might make it difficult to make a memory about something. For instance, if your oxygen levels are low and your brain's not functioning completely, then you might not be able to make a memory and maybe not hold on to a recent one. Or if the blood flow, if your heart function is so poor it's not delivering enough blood and oxygen to the brain, even though the oxygen is technically normal in the bloodstream, that could also make brain function less efficient than it should be. But as a symptom of pulmonary hypertension, I don't believe I've ever had anyone come and say, my memory is bad and therefore it must be the pulmonary hypertension. I don't know about...
Yeah, I think it would make us think of other things that coexist with pulmonary hypertension, for example, sleep apnea that's untreated. Yeah. So people who are sleep deprived, sleep apnea is a condition where people stop breathing at nighttime and they have pauses and they get low oxygen levels at nighttime, and that puts a strain on the heart, puts a strain on the lungs, and can cause pulmonary hypertension. It also puts a strain on the brain, and so people have memory issues and concentration issues during the daytime. And so we would look for, I think, for some of these concomitant conditions that can cause both.
But I would ask that you ask your patients if they've had memory loss, because like I said, at our groups, there isn't one person who hasn't had that problem. They just forget to tell the doctor because we have memory loss. But honest to goodness, it's one of the lesser things. You just forget about it because there's so many other issues. But honestly, I bet you if you ask anybody in here if they've had trouble with their memory, they're going to tell you yes.
Well,
they really are.
And let me just take that a step further. This is an area that we have not focused on, and we should. I think we get so focused in the heart and lungs and keeping you folks alive that some other things that feed into the quality of life have been somewhat neglected by the community. I say this because one of the emphasis of the PAHA over the last couple of years is to highlight the levels of depression that a lot of our patients have. And I think we've all underappreciated how much depression impacts our patients because you have a chronic disease, just like someone with cancer, diabetes, or, whatever. And depression can sometimes affect your memory as well, too. But the point is, you're right, we haven't paid enough attention to this issue. And it's something that, I know there are some of our colleagues who are actively doing some research in this area, even developing some screening tools to look for some of these things. In our PH patients, because it's probably something, it's interesting. It's like for so many years we just wanted therapies to keep you folks alive. Now we're doing that, and as Joel alluded to, now you have time to get other medical problems like kidney problems, liver problems, cancer, thyroid, depression. So we're working on it. We'll try to do better.
You actually just touched on my question. That's what I was going to ask. When I was 26, I was diagnosed with thyroid disease. And 4 years later, I started showing symptoms of PH. So I was wondering if they're doing any studies. Is there anything coming out in relation to thyroid disease and PH, since it is an autoimmune disease?
And actually, both are well established to be associated with pulmonary vascular disease. So hypothyroidism especially, and any autoimmune disease. So yes, and we already have done those studies.
About a third of patients with PAH have some evidence of thyroid problems along the way, and whether people had hyperthyroidism, contributes to the development of pulmonary hypertension at some time, or the two just kind of track together, we don't really know. But it's definitely a common association.
In fact, every one of our new patients, we screen for thyroid disease as part of the presentation.
I've learned so much from you today. I really appreciate it. And just the categorization, well, I discovered that I'm 2, 3, and 4. But I have a crackpot theory, and I thought, what better place, right? And that is, what affected low blood oxygen from undiagnosed sleep apnea and pulmonary hypertension? What effect might that have had on my retinas? Because I know they're very sensitive to oxygen.
Well, I'm not an ophthalmologist, and I don't play one on TV. So,
and he didn't sleep in a Holiday Inn.
Right. So low oxygen levels play a role in the development of pulmonary hypertension, and we do see it a lot in sleep apnea. Treating sleep apnea has been shown to improve the pulmonary hypertension that exists. Pulmonary hypertension in sleep apnea is usually fairly mild. It's not usually as severe as we see with other causes. In terms of the impact of low oxygen levels on retinopathy or glaucoma, I really can't comment. I don't know what the impact there would be. It's probably not helpful, though.
I noticed a difference when I was on oxygen therapy.
Your vision got better?
Yes.
Yeah.
This is really fascinating. Yeah. At night in dim light, I had like a blind spot, and it was much better when I was on oxygen.
Yeah.
And then when I was successful.
Oxygen does help a lot of things out.
Oxygen is good.
Good morning. My name is Gloria. I was diagnosed 13 years ago. I wanted to know if PH can also cause you to go into AFib.
PH can cause AFib?
Yes, I went into AFib in November.
It can definitely lead to atrial fibrillation because with those pressures and resistance downstream, what we talked about earlier was that the heart chambers can get bigger and start to stretch, and that can lead to really disruption of the normal conduction pathways, and it can lead to atrial fibrillation or atrial flutter.
Thank you. We were talking about sleep apnea. I was diagnosed with sleep apnea many, many years ago, and I have one doctor who believes firmly that that's the cause of my PAH and wants me off the CPAP immediately, like as fast as I could possibly lose all this weight.
Did you say off
your CPAP?
And then I have another doctor who says, no, the CPAP is good for me.
Yes.
But I do know that I desat at night to about 88, and I'm curious to know at your centers where you draw the line on when you use supplemental oxygen at night for people who desat. During the daytime, I'm up at 95 or 96 for oxygen levels, but at night I go down to 88, and that was shown during
if you've had a formal sleep study, it should be very clearly detailed on your sleep study what you need. And sleep apnea causes a form of pulmonary hypertension. Sleep apnea needs to be treated, as does desaturation
well, it is.
at night.
I've been on CPAP for 12 years, and when I desat it, I was in a sleep study and on the CPAP at the time. So.
Right. So your question is when to supplement oxygen?
When to supplement.
Yeah, and so we do at least overnight oxygen testing on everybody, and then we'll do sleep studies on people where we have concerns that they have concomitant sleep apnea. Pulmonary arterial hypertension, pulmonary venous hypertension, lung disease can all cause low oxygen levels at night. So even in lung disease without pulmonary hypertension can cause low oxygen levels at night. So we do try to test for everybody. That's one of the cardinal recommendations for the evaluation. And we do treat anybody if their oxygen level at night is below 90% roughly. Yeah. And for what period of time, if you dip that down below 90% for 1% of the night, it's not really clear where to draw the line on that, but, many significant desaturations in the oxygen level below 90 we would treat, either with supplemental oxygen, CPAP if you need it. If the CPAP's not enough, so it controls the sleep apnea, people can still desaturate, then we would add oxygen to that. So what we call bleeding in oxygen into the CPAP device. Yeah.
Yes, I was diagnosed with scleroderma about 13 years ago. I was never on any medication, and I continued to exercise and kept healthy eating and all. But about 2 years ago, my echo started to show that there was some increase in the pressures. So I was followed up with echoes, and then this last year, my cardiologist said I should get a right heart cath. So I wanted to know at that point, what was it going to do for me? Because I knew if it's just borderline, and it is because of scleroderma, there really isn't any treatment for it. So I went to see a PH specialist, and he put me through all tests again, and came to the conclusion that at this point, right heart cath is not going to give him any more information. So what do you all think about that?
Maribeth, you want to maybe tackle this one?
So is your question more about the need for the right heart catheterization?
Correct.
Mm-hmm.
Yeah.
So I think, as the doctors have alluded to, it's very important to get that information from the right heart catheterization. And when you say the decision about treatment, nothing that could be offered or done, I think that it's important first to see that information, because if your hemodynamics, or those important pressures and numbers that they get from the heart catheterization, are elevated to a point that you could benefit from some treatment, even if it's something that we don't have, where it's been studied specifically in patients with scleroderma. There are some patients on those treatments, and they are getting benefit from those treatments. So I think the right heart catheterization would be very important to better categorize the degree of the disease for you.
Without knowing, what exactly your echo is saying, it's a little hard for us to comment as to why the PH expert said that it wouldn't add anything at this point. I think this gets back to some of the comments we were making earlier, that one echo is not the same as the next echo, and a lot of it depends on which lab is doing it and who's interpreting it. And it's possible that the PH center, the expert you went to see, based on their echo, they were reassured that there isn't significant pulmonary hypertension. I think if they were, as Maribeth alluded to, it would be important to do the heart cath before you started any therapy. And this gets back to the issue of using the echo as a screening study. There are very few populations or groups of patients that we recommend getting echoes every so often. Scleroderma is the one group that we do because of the increased risk of PH and scleroderma and our ability to start worrying about it before it even happens. I mean, you had a diagnosis for almost 15 years, and we know that there's a risk of PH, so your doctors have been doing periodic tests. Well, there's kind of this idea in medicine: the more times you go looking, the greater the chance you're going to find something wrong at some point. And it's possible that one of your echoes, the one you had by your local doctor, may have been a little off and made him or her worry. But then when you got to the center and they did their echo, they were reassured that it really looks okay. And if this is in the context of you feeling good and not noticing any symptoms that have changed over the last year or two, it could be reasonable just to keep watching you.
Okay. Thank you.
All right, we're just about done. We have 2 minutes left. There's a question right in front there.
Hi, our daughter has PH, Kimberly, and we was told that when she found out that she had it, she needed a double lung and a heart transplant right then and there, and she refused it. Can you tell me which category is that ranging when they tell you right there that your child needs a double lung and a heart transplant? But
as the first thing to do, that was the very first thing they're recommending.
Yeah, because see, she was misdiagnosed about 3 to 4 times by different doctors until we got her to the right hospital, which is Inova, and they told her that she needed 2 lungs and a heart transplant.
So, is there a congenital heart disease, some type of heart defect that she was born with?
No, she was a healthy child until at the age of 30 she was diagnosed that she had PH.
I think we could just speak generally on this because we don't know all the details here, obviously, as to why. I mean, 20 years ago, the only treatment that was available for patients with pulmonary arterial hypertension was a transplant. And originally it started out as only heart, lungs, and then pretty quickly we realized, hey, we can save the hearts for other people and just do the lungs. And up until the late 90s and this past 15 years, until medical therapy came around, that was still sort of the approach we took, okay? But in general, I think we all feel that medical therapy is the first thing to try, and in general, we don't usually move forward towards a transplant until patients have had a good shot at medical therapy and are not demonstrating a good, adequate treatment response, okay? I don't know the particulars about your daughter's case and why it was mentioned that a heart-lung transplant be immediately done, without the details. But again, in general, we reserve that option for patients who either are failing medical therapy or for some reason are not good candidates for medical therapy, which is exceedingly low or rare. All right, folks, it is 9:45. I hope this has been helpful. We've had a lot of fun doing this. You guys have had some great questions. Thank you.
Good question.